But what can us as students or as voters or as educators do to assist in what you're doing or even help your organizations in some way?
Well, I'd start by saying vote.
Yeah.
I mean, it sounds like a really small thing, but it's huge. And I really, you know, the old saying is, you know, all politics is local, and if you don't know your state rep or your state senator, you should, because those are people that you can actually talk to and who will give you an audience, and you can say that this is what I want. A couple of years ago, someone was running for state rep in my district, and he sent out a mailer that showed he had a gun. So, you know, tough on crime. You know, vote for me, I'm tough on crime. And I just happened to be at one of his fundraisers and cornered him, and you know, he's still traumatized. Because I gave him an earful and then some, because I said, you know, tough on crime doesn't work. We need to be smarter on crime, and let me tell you why. And that led to a 30-minute discussion. And I ended up not voting for him, but I made sure that I gave him an earful. So, you know, I think, you know, because of what Dr. Holton said about legislators being so reactive, and those kinds of reactions generally don't lead to good laws or good public policy, what you should do and what you can do is vote. I also think that all of you should be or could be emissaries for what works. And what works? What works is putting money into community services. What works is intervening with kids early. What works is our evidence-based practices that have proven track records. And what works is understanding who kids are. And just as an example, I'll say, you know, raise your hand if you've never done anything that could get you stopped by the police. Okay, how about in the last year? Okay, so what does that tell you? I mean, we're not a bunch of marauding criminals in here, but what it should tell you, I think, is that at least in terms of adolescents, they do some things, they make some judgments that are not great judgments, and that shouldn't lead to a lifetime of punishment, and that we should do the things that we need to do to give them the support and the direction that they need to go on to become productive adults. So when I talk to people who aren't shrink types like me, I say, you know what, adolescents are like race cars with a steering wheel that doesn't work and no brakes, right? Go really, really fast. Steering, not so great. On, off, stop, start, not so great. They need a little bit of direction and they need a little bit of guidance. But other than that, they grow out of it. We did. We did. And kids can. If we have those kinds of supports, if we vote the right people into office, if we're not overly punitive, if we communicate a message of hope, and also, and this is the other part of it, we hold kids accountable. Just because you're invested in rehabilitation doesn't mean you give them a free pass for bad behavior. I think you can do both. That's not the dialectic. But what we can't do is punish and expect kids to move out of and sort of rehabilitate themselves. We've done that, and it doesn't work. So that's what I would say.
Yeah, we kind of touched on this because I attended the 17 panel earlier today, and part of the problem is that during that time frame, their brains aren't fully developed, and that's part of the cause. And why, you know, and especially 17-year-olds being tried as adults when they shouldn't be, because they're not fully developed. I just think that this panel fits in really well with that.
Yeah, there's a lot of really interesting stuff going on with brain research and brain development. And just a really quick thing, one of the things that they've found with the new technology is that there's this development that happens when kids are 13. So we know it happens when they're newborns as they're learning their capabilities, but it also happens at 13, 10 to 13 when kids are coming into puberty. What does that mean? It means that their brains are still developing, and that maybe we need to look at kids, teenagers in particular, in terms of their brain development and what they're capable of.
I was just wondering, kind of a question for all three of you. Within the current DSM, it's pretty easy to medicalize a lot of problems and to assign a proper treatment option based on the symptoms and everything. What are your views, especially for youth, of kind of following this medicalized pattern that is within the treatment options or what's recommended within the DSM versus some of the more alternative treatment methods that might not include such a medical approach?
Shall I? Okay. So, we shouldn't label kids. We should, I mean, why do we do it? Because we do it primarily for insurance purposes, right? If you want to get reimbursed for insurance, you have to say, this is the diagnosis, this is what I'm treating. But if I tell you, this person has major depression and this person has major depression, I've told you nothing about that. They can be very, very different. When you're talking about kids, adolescents, and young kids, you're much better off talking about their capabilities, what they can do, what their strengths are. That informs what you can do with them much, much better. As John was talking about earlier, if a kid is interested in knitting and that's their strength, then I want to know about that so I can leverage that to get in and do some other things with him. Just saying to me that he's got a major depression doesn't tell me anything, and I'm a shrink. So, I mean, I recognize, I really try and get people not to talk about kids or people in terms of diagnoses, because it doesn't really tell you anything about them, and those labels stay with you forever. 10 years ago, the in vogue diagnosis was ADHD. Does anybody remember that? Everybody was ADHD. Well, now it's bipolar disorder, because everybody has bipolar disorder. And the diagnosis of bipolar disorder has gone up 400 times. 400 times. Okay? So, are there more bipolar kids rolling around? I don't think so. I think it's just, I mean, that's what happens when, you sort of label kids and their fads and that kind of thing. I think we're much better off as clinicians, as interested people, as providers, talking about what kids can do and what their capabilities are, what their strengths are, what their interests are, what their needs are, rather than saying, well, he's on page 483 of the DSM and here are his symptoms. That's really not as helpful.
The other, just to complement what Dr. Ferguson just said, we are a mental health agency, but we inquire about the non-prescribed medications that kids may be using, from cigarettes to marijuana to cough medications, etc. And it's very interesting. So there are some children who feel what's the word? Perhaps it's insecure, that having something that blurs reality is a way of establishing themselves in a place like BBF. And you want to probe that, you want to work with that to understand it. So I think there's a place for medication. I don't think there is. I think we use it as to opt out for doing some real work, and it does have a financial incentive associated with it, which